like common flu. But you are not going to think about HIV infection first. How or when you are going to think about immune suppression? I'm not saying HIV, but immune suppression. When a patient is coming with recurrent infections which are not treated by the routine antimicrobials, so kindly think about immune suppression. That may be a patient is having a cancer, a patient may be on an immunosuppressive drug, a patient may be on chemotherapy for some malignancy, a patient may be on radiotherapy, or there may be a history of chemo or radiotherapy in the future, oh sorry, in the past. So you don't have to think HIV uh, on the very initial diagnosis, but you may think about immune suppression. And there are thousands of other causes of immune suppression. But what our routine is in the clinic, that whenever you label a patient having immunosuppression, you label the patient as having HIV. So you don't have to diagnose HIV there and then without any investigation. So HIV emerged as a disease, and it has a huge impact on the entire globe. So see these posters in back 1980s. So HIV in our part of the world, or in Pakistan, is actually the tip of the iceberg. The tip of the iceberg means that what we know about HIV in Pakistan is not the real picture. So we only know a few cases, we only know a few areas, but the actual burden is more than what we know. And that is something unfortunate. I'm going to discuss that in a few minutes. So see this, that in many parts of the world, the HIV infection is uh, not prevalent, but in certain parts of the world it is prevalent. Actually, HIV is present all around the globe. HIV vaccination is underway, just like many other vaccinations, but it is not marketed yet, because HIV has two strains, HIV-1 and HIV-2. It is a retrovirus and it is an RNA virus, and vaccines against RNA viruses are a bit difficult to develop. But this vaccine is actually in a lighter mood, that this is some kind of a political um thing also, because uh, after a long time we don't have a vaccine for HIV, but uh, there were vaccines which were said to be against HIV in the past, but they were not marketed as such around the globe. So HIV vaccine is one of the vaccines that let's see what or where or which country is going to launch, and they are going to take the lead. So the causative agent is human immunodeficiency virus. It is a C-type retrovirus from lentivirus family. It is an RNA virus, and there is a viral membrane containing some proteins or antigens. I'm going to show you the diagram. So it has a reverse transcriptase enzyme in the core. So that reverse transcriptase is going to reverse the RNA present in the virus into a DNA, and that is then inserted into the human genome, and then the viral replication starts. So see this, this is the structure of HIV virus. There is a core, and there is RNA, and you have reverse transcriptase enzyme there, and you have a capsid or a membrane around. So there are certain important proteins which act as antigens and against which antibodies are formed by our immune system. So these are some of the antigens. Antigens are actually the proteins related to the virus. So on the envelope, you have GP120 and GP41. So these are the envelope proteins. You have GAG P17 and you have GAG P24. And then you have the RNA of the virus. All these can be detected through serological tests, that is ELISA, Western blot, and PCRs. So what are the risk factors? So in this slide, you can see that again, uh, uh, the sexual activity is on the top, but it is not the state of affairs in our country. Yes, unprotected sexual activity in the homosexuals and multiple partners. Yes, that exists, and that is one of the cause of transmission of HIV. But very important are blood products which are transfused. So blood as a whole and the blood products which are transfused are one of the biggest culprits in our part of the world. This is what I have seen in my small experience in pathology department, in our wards, and in our health department. And what we are practicing is that whenever there is a patient of HIV, we first label the patient as he or she got that HIV from certain sexual activity. Yes, that cause also exists, but the cause we are always ignoring are the blood products. Why blood products written last in this slide? Because all around the world, this is one of the least important cause, because they always screen the blood and the blood products before transfusion, and this is what we are not doing in our country. The second most important cause in our country is the intravenous drug abuse. So intravenous drug users, they are at high risk, and they are spreading HIV amongst themselves and then amongst others also. So unprotected sexual activities, used needles, used surgical blades or blades used at the salons and barber shops. There may be transmission from infected mother to the fetus, that is called the vertical transmission, and then infection from blood products, that stays number one cause according to me in our country, because I'm highly emphasizing on this thing that we are not screening the blood and the blood products before transmission. I have seen many patients who were diagnosed as having HIV, and they had certain blood transfusions in the past, and those blood bags were not screened for HIV. As you all have seen that many a times when you go for blood screening or for donating a blood, many a times people come out as having hepatitis B or C without knowing previously that they have this infection. Same is the case with HIV, because we don't screen properly. Only certain big labs are screening this the blood before transfusion for HIV and hepatitis. But this is not the state of affairs all around Pakistan. So blood products and particularly the intravenous drug use in the addicts is one of the biggest cause of HIV spread in our part of the world. Reuse of syringes is also one thing, because as you have seen that syringes, they are just thrown in the normal routine waste, and they are reused. So this comes from the West. This may be the percentage may differ in our country. So in our country, the other two causes, they are more important. So, AIDS is not spread by touching. AIDS is not spread by the bite of the mosquito. AIDS is not spread by working together, sharing food, clothes, or even the toilets. So, AIDS or HIV infection is actually a stigma in our country. That is why the percentage or the number of the cases we know are far less than the actual picture. So, what is the mechanism of infection? There is a severe loss of CD4 T cells. CD4 T cells are one of the first cells which are infected by the HIV. So, virus binds to CD4 molecule on T cells by GP120. GP120 is one of the envelope proteins or the antigens, and it is going to bind to the CD4 cells. Other than CD4 cells, macrophages are the second culprit, which are the second cells which become infected by the culprit, that is the HIV virus. Then astrocytes or other body cells can be infected, but in cases of immune system, CD4 T cells and macrophages are the prime cells which are infected by HIV. Then yes, other cells may also be infected, like the B cells. Viral RNA is reversely transcribed and integrated into the host DNA, and then copies of new viruses they are produced. They are then they are going to infect the other T cells in the surroundings, and that is how the viral loads rises. So HIV attacks the T cells and then makes the copies of itself in those T cells. So this is a summary of how the infection of HIV occurs in T cells. So CD4 are cluster of differentiation, and they are present. They are antigens or proteins present on the T cells. They act as receptors, where GP120 on the HIV cell is going to attach, and then the viral core or the RNA is then taken into the cell and into the nucleus, where the reverse transcriptase already present in the viral core is going to transform RNA into a DNA, and that is then incorporated into our human genome, and further copies are formed. So, HIV infection is the initial stage. Now, from here onwards, make it very clear that HIV is the initial stage of the infection, while AIDS is the fourth stage, that is the last stage. So HIV infected patient is going to undergo three stages when we call the patient as having HIV infection, or the patient is HIV infected. And when we are going to call AIDS, that is when the patient is going to present with super added opportunistic infections and certain malignancies which are particularly seen in the HIV infected patients. P23 antigen, it rises initially whenever there is insertion of HIV infection into the body, and that is going to lower down very soon. then IgM antibody is formed against this antigen, and that is going to again fall down. But IgG antibody against P24 antigen is going to stay for a period of time. And this is the initial period of HIV infection when there are no symptoms. So the patient presenting with a fever or a sore throat or a flu-like symptoms, you may not go for HIV serology. So these are the initial antigens and antibodies which can be found. So, what is the cellular response in HIV T cells? They are lost and they are going to decrease in according to the stages of HIV. There is decrease in response to antigens then, and there is decreased production of cytokines, particularly interleukin 1 and interferon gamma. So B cell decreases the response to antigens, and they cannot produce antibodies as the stage advances. And similarly, macrophage, when HIV enters the macrophage, the capacity of the macrophage to engulf and phagocytose the microbes is decreased. So, what is the natural progression of HIV disease? It is 1, 2, 3, and 4. So, you may have acute infections that may include fever or skin rash or sore throat or flu like symptoms. But obviously, you are not going to call it HIV initially. You may investigate for certain other bacterial infections first, then viral infections, or maybe some parasitic or fungal infections. And if you don't have a diagnosis, then even clinically, you may not go and rush for the HIV investigations. Group B again is asymptomatic. So there is a latent period of the disease that may extend from 7 to 10 years. That is a symptomless period or a disease free period when the patient is not going to present with any particular symptoms which is particularly seen in AIDS, or in this period, the patient may not have any opportunistic infection which is not treated with the routine um, antibiotics. So, group three is that the patient now is going to acquire infections which are not properly treated by the routine antimicrobials, and there may be persistent generalized lymphadenopathy. And again, in this generalized lymphadenopathy, you may think about other common infections first, like tuberculosis, like infectious mononucleosis, or lymphomas. If you rule out these, then you may go for certain other viral infections first, and then you can jump on to HIV in your differential diagnosis. So, AIDS related complex. So, stage 3 or group 3 becomes AIDS related complex. Still, we are not calling AIDS. So, in the initial two stages, we call the patient as having HIV infection. And in group 3, you may call it AIDS related complex if you see certain opportunistic infections like candidiasis, like oral hairy leukoplakia. That means there are white patches which are not treated by any topical medicines. You may have lymph nodes which are not regressing. You may have persistent skin rash, a weight loss that is not related to any other infection, or if you rule out malignancy, you may say that this weight loss may be due to some infection, that is HIV. Herpes is a super added viral infection, and that can reoccur because of the immune suppression. So, in cases of acute HIV infection, you may have symptoms which are not particularly related to AIDS, but they may be related to any of the body systems, but they are not particular to any certain disease. So you may have nausea, vomiting, rash, myalgias, weight loss, fever, or any other symptoms which can be related to thousands of other diseases. So people with healthy immune system can be exposed to certain viruses and have no reaction to them. But in case of HIV, they may have opportunistic infections, and they may have recurrent viral, bacterial, fungal, or parasitic infections. So opportunistic infections means that these are certain microbes which are present around us, which are present in the environment, certain microbes which are present in our body, living as commensals, but they become opportunistic because they got opportunity because of our suppressed immune system, and they can attack our body. So group 4 is particularly related to the opportunistic infections, and these are some of the opportunistic infections. So if you see toxoplasma infection in a patient, you may label the patient as immunosuppressed. If you see certain fungal infections, like we did Cryptococcus neoformans, meningitis, recurrent candidiasis, and Pneumocystis carinii, that is now called Pneumocystis jirovecii. Bacteria like Mycobacterium and atypical Mycobacterium, particularly, then certain virus like cytomegalovirus, herpes, and varicella zoster virus, and recurrent infections of such virus must uh, make uh, you particular about that you are dealing with opportunistic infections, and these type of infections and recurrent infections with bacteria and viruses are not seen in an immunocompetent patient. So if you see cryptococcus, recurrent candidiasis, particularly pneumocystis infection, toxoplasma infection, that must lead you to the fact that the patient is immunosuppressed. You may have secondary neoplasm in a patient of HIV. Kaposi sarcoma is one of them, and Kaposi sarcoma may be seen in a non-HIV patient also. But if you see a Kaposi sarcoma in a person who is not previously diagnosed as HIV or AIDS, you must go for the diagnosis of HIV first, and then if the patient is HIV negative, then you may label it as having Kaposi sarcoma from a strain that is not infecting the HIV patient. So there are certain strains of the virus which is causing Kaposi sarcoma, which infect particularly the AIDS patient, and then there are strains which are uh, infecting the immunocompetent patients. So you may have other malignancies also, but Kaposi sarcoma is one of the best malignancy related to HIV patient. So this is a list of opportunistic infections, and you may have routine infections also. But if you see those routine infections reoccurring many a times or are not treated by the routine antibiotics, then you may have a suspicion of immune suppression. So this is stage 4. You may see Kaposi sarcoma. So see this. Kaposi sarcoma is mostly seen on the skin, but it can occur anywhere in the body because it is an intermediate tumor of blood vessels. So see the facies of AIDS patient. Now in stage 4 or group 4, we are going to label these patients as AIDS. In the first three, we are not going to call it AIDS. We are just going to call HIV infected. This is Kaposi sarcoma. So see this. This is Kaposi sarcoma. You have candidiasis or oral thrush. You have multiple tumors on the face. You may have multiple tumors on the skin or anywhere in the body. So these are human papilloma related tumors, which are squamous cell carcinomas on the lips. So see this. This is the summary of the opportunistic infections. You have wasting of the body, just like cancer, and you have multiple infections. So at this stage, this patient is going to die because of the multiple infections. So HIV itself is not going to kill the patient. HIV actually suppressed the immune system, and the opportunistic infections which are not treated properly now, they are going to kill the patient. So how are you going to diagnose HIV? So antibodies appear 6 weeks to 6 months after the exposure, and antibody against P24 and GP41 appears before antibodies to other genome products. So you may go for antibody testing with ELISA or with PCR. So um, the tests for HIV, first is a screening test, that is a chromatographic test. You may take a blood drop, and if there are antibodies against the antigens of HIV, you may screen the population. So screening test is particularly required for a mass or a population if you want to screen them for HIV. But if you have a positive test on a screening device, you always have to go for ELISA test. And if ELISA is also positive, you have to go for PCR to confirm the viral load. So these are some of the tests. You may go for P24 antigen, P24 antibody, or HIV RNA in the plasma. And um again, emphasizing on that you don't have to rely just on the screening test. If somebody is screened positive, you have to go for the ELISA PCR, and then the confirmatory test is the Western blot testing for HIV. So HIV testing is for antibodies to the virus, and then ELISA is enzyme linked immunosorbent assay, and then ELISA is confirmed by Western blot testing. ELISA and certain other tests, we are going to deal them in detail in serology or serological techniques later on. Then you can go for viral load and CD4. Once the patient is diagnosed with HIV infection, he or she is followed uh, periodically uh, by viral load testing and CD4 count to determine the stage of the disease. So you don't have to go repeatedly for ELISA or Western blot, but once the patient is a diagnosed case of HIV, you will go or follow the patient with viral load and CD4 count. CD4 count can be done by flow cytometry. Uh, Flow cytometry is also used in hematology for diagnosing lymphomas and leukemias. So these are some of the um, tests you can go for in a patient of HIV. So ELISA or immunochromatography, Western blot, and immunoblot. So HIV-1 and HIV-2, these are the two species which can infect the human. So you don't have to remember this slide. You just have to remember the names of the test you are going to order. So treatment is prevention. So you can decrease the risk of HIV by preventing the disease rather by curing the disease. For the cure of the disease, antiretroviral therapy can help in increasing the number of CD4 cells infected by HIV, or you can give some prophylactic antiretroviral therapy once the patient is diagnosed, so that you can just prolong stage 1 and 2, or you can prolong the latent period. You are not actually treating the disease as a whole. You are not treating the patient that the virus is going to become zero in your body, or the virus is going to disappear from your body, but you are actually increasing that latent period, so that the patient may not get opportunistic infections, or the patient is not just rushing to the stage 4. Uh, so antiretroviral therapy is going to decrease the viral load. It is going to decrease the infection in the CD4 cells, so that the immunity is not suppressed. But you cannot make the virus disappear from the body. Same is the case with hepatitis B and C. When you are giving therapies for those viruses, you are not actually making them disappear from your body. They become dormant in the hepatocytes and may infect the body again. Same is the case with HIV. HIV virus may show a zero load in your blood, but it is present in the body in certain cells and may reproduce, reproliferate, is going to re-emerge after some time. So antiretroviral therapy can show you a negative report after the treatment, but that doesn't mean that the patient is free of HIV. You have to follow the patient then. So it is antiretroviral therapy. It is called ARD, that can help the patient to live longer. It lowers the risk of developing HIV related illnesses and decreases the chances of transmission to other people, like from mother to fetus, or sexual activity in case of a couple. So the treatment is against the enzymes against reverse transcriptase, and there are certain protease inhibitors. There are transcriptase inhibitors, and there are enzyme-related drugs which we give as antiretroviral therapy. So this is what you are going to deal with the therapy in your pharmacology. So there may be combined therapies, or there may be highly active antiviral therapy in which you give cocktails according to the symptoms of the patient or according to the stage of the patient. So ignore this slide. There are a number of drugs which you might have done in your pharmacology. So, post exposure HIV follow up is that you have to give first aid if somebody is having a needle stick injury or an accident, and if the accident or a needle stick injury is from a patient who was already diagnosed as having HIV. The best treatment or the first aid is to wash the area with the soap and the running water. And you don't have to panic, you don't have to be horrified. Just squeeze that area so that you can clean that prick by running water and soap. The soap becomes a disinfectant. So evaluate the wound if it is a bigger wound, evaluate the fluids, that is blood and the saliva, and then evaluate the patient who was a patient of HIV, whether the patient was actually the patient of HIV, or the patient was treated with ART and his serology is negative. Then the biggest fluid or the mode of transmission stays blood. So the blood stays the biggest, mode of transmission. All other body fluids are minor mode of transmissions. So urine, saliva, tears, sweats, or any other body fluids. But yes, body fluids can also spread HIV, but blood stays the biggest culprit. So you have to prevent any needle injury. You have to prevent injuries from used needles, from used blades. So this is what is important, that as a health worker, as a doctor, as a health professional, kindly educate your family, kindly educate your surroundings, kindly educate whoever is coming as a patient or the attendant to your clinic or your ward or uh, anywhere, so that you can spread a message. Uh, and like I said initially in the lecture, that in our part of the world, the blood products are one of the biggest culprits. Please, I'm saying this again and again and again, that yes, sexual activity in our country is one of the uh, mode of transmissions, but blood and IV usage, or syringes and granulas, they are one of the culprits.
So sorry to interrupt you. Actually, just 1 minute left.
Okay, Ji. So these are all what we have already discussed. So in cases of pediatric AIDS, the babies who are infected through vertical transmission, they are to be screened and then treated. So this is the last slide. So prevention stays the treatment. So you don't have to actually cure AIDS, and you don't have to stay away from educating the people and then talking about AIDS or HIV. That is the only thing we can prevent AIDS or transmission of this infection. This may become a pandemic in future, maybe, because many a times when we are hiding something, it becomes dangerous. So let's hope for the best. And see, this is the data or the statistics of 2012. I couldn't find the latest, but you may imagine that this is the state of affairs in the world, uh, and what can be the state of affair in our country uh, if we are hiding. And that is just the tip of the iceberg in our part of the world. So that was all about HIV and AIDS, and we are going to meet in the next online lecture with another topic. Thank you so much